Good evening and welcome to UT Southwestern Science Cafe. We welcome both our regulars and new guests to this ongoing series. My name is Charlondra Thompson and I'm a part of the public affairs team here at UT Southwestern. This is our third year to host Science Cafe and we are proud to produce this series. On behalf of my colleagues, Jenny King and Joya Lang, as well as our guest speaker, Dr. Nneka Ifejika, we welcome you and thank you for joining us tonight. Science Cafes are online conversations where our speakers take you on deep dives into science topics. At UT Southwestern, we are an academic medical center, which means we bring together research, medical and health education, and patient care into one institution. Research and education informs care advancements quickly, which is a benefit to our patients and community. We also have fun at Science Cafes while we learn. Our format is casual and interactive, and we encourage you to ask questions and engage with us during the program. This evening, we are discussing the future of stroke prevention, care, and recovery with Dr. Nneka Ifejika. More on her in just a moment. We have a few technical points to cover before we begin. We are recording tonight's program as well as live streaming it on our UT Southwestern Twitter page. Please mute your microphones to help everyone's audio clarity. We encourage you to use the chat feature to list questions for Dr. Ifejika. We are monitoring your questions in the chat box, and Q&A will start at the conclusion of her presentation, with Joya facilitating this part of the program. And finally, we cannot answer personal medical questions, and we would love to hear from you with your general with your general questions, excuse me. And with that, I'm pleased to introduce our guest speaker. Dr. Nneka Ifejika is an associate professor of physical medicine and rehabilitation at UT Southwestern Medical Center with secondary appointments in the departments of neurology and population and data sciences. She is also the section chief of stroke rehabilitation. Her research focuses on transitions of care after stroke, stroke outcomes, and health disparities. Among her many honors and accolades, Dr. Ifejika has received 2 United States congressional commendations for her innovative work in underserved populations affected by cerebral vascular disease. In 2019, she became the first UT Southwestern and first African-American recipient of the Association of Academic Physiatrists Early Career Academician Award. She is the only female physical medicine and rehabilitation physician who is a fellow of the American Heart Association's Stroke Council, and she is an assistant editor of the peer-reviewed journal Stroke. Dr. Ifejika, thank you for joining us this evening and welcome to Science Cafe. The virtual podium is yours.
Thank y'all so much for the wonderful introduction, and hello everyone from my living room. This is not a screensaver behind me, this is the actual painting. So if you see potatoes, you know it's me if I'm giving a virtual talk from my dining room. I'm gonna share slides and we're gonna get it started. All right. Can y'all see my title slide? Give me a thumbs up. All right. So the topic of this discussion today is going to be the future of stroke prevention, treatment, and recovery. I am what they call a physical medicine and rehabilitation doctor, but I specialize specifically in cerebral vascular disease, and we'll get into the reasons why I chose this as my field and my calling, and some of the work I've done in the past, how it informs my current work, and where I see stroke recovery going in the future. So here are my disclosures. And let's get started with some stroke statistics. So every year, more than 795,000 people in the United States have a stroke. That equates to 1 stroke every 40 seconds. Every 4 minutes, someone dies of a stroke. And then out of the 795,000 people affected, around 610,000 are first or new strokes. And about 1 in 4 are in people who have had a previous stroke. I like to show this chart to essentially show where Dallas is. So kind of right here. We're technically not in the stroke belt, which is the southeastern United States, but we're pretty much at the edge of it, aren't we, everyone? So we have a higher incidence of stroke. This is ages 35 plus by county. And we're going to have a conversation about that too. Stroke is not just a disease of people over the age of 65. The incidence and prevalence is actually increasing a great deal among younger patients. Let's talk about what this means in terms of the actual demographics of this country. And so by the year 2035, more than 130 million adults, or 45.1% of the population of the United States, are projected to have some form of cardiovascular disease. That includes stroke. It is a leading cause of long-term disability in the United States. About 3% of males and 2% of females reported they were disabled because of stroke. And by 2030, an additional 3.4 million US adults greater than 18 years of age, representing 3.9% of the adult population, would have had a stroke, which is a 20.5% increase from 2012. So it is a prevalent problem in our community. So what are we going to do about it? And what is the role of post-stroke rehabilitation in the terms of cerebral vascular disease? Let's talk about it. This is me about 10 years ago at my previous institution. I was a member of the UT Houston stroke team for about 10 years. And I basically lived at the nurses station where you can kind of see me charting. And the rehab unit was right next to the stroke unit. And so I realized very early on that I needed to work on stroke rehabilitation starting at the bedside. And I meant the acute stroke bedside. And I was very concerned about specifically complications. What happens once you get hospitalized, which was right on target with the stroke rehabilitation guidelines. So you can see here in quotes, equally important in rehabilitation is to protect the individual from developing new problems, including pneumonia and urinary tract infections. So you want to focus on the most common problems in the hospital and how to reduce them. So that was the first focus of my research. And so I want to go over a little bit about what stroke severity is and how it's measured. We use two primary measures for stroke disability. One is called the modified Rankin scale. It is on the left-hand side of the screen. It varies from a 0, which is no symptoms, to a 6, which is death. And then the NIHSS, which counts for the National Institutes of Health Stroke Scale. And you can see here how we grade 0 stroke symptoms, minor, moderate to severe, and severe stroke. So throughout this talk, I'll kind of refer to either the modified Rankin scale or the NIH stroke scale to talk about stroke outcomes and stroke severity. So I decided to look first at healthcare-associated infections because why? They're common and they commonly cause problems if you're hospitalized for a stroke or any other cardiovascular disease. So they're one of the most leading causes of preventable death in hospitalized patients. Healthcare-associated infections are. Aspiration pneumonia among stroke patients is the most common form of hospital-acquired pneumonia. And symptomatic urinary tract infection was the most common healthcare-associated infection, period. It accounts for 1/3 of healthcare-associated infection complications. So I thought, let's focus on these two and how they impact stroke outcomes and access to post-acute rehabilitation care. And so I did. This is a paper I published about 10 years ago where I looked at patients who had aspiration pneumonia. You can see here, follow the arrow sign. This is the pneumonia. And we looked at about 5 years of data. You can see here, my sample size was about 4,971 patients who were admitted to the stroke service at my institution. And my objective of the study was to identify factors that increase aspiration pneumonia and to increase the rate of discharge to post-acute rehabilitation. So the most important thing about getting post-acute care is what happens, the intensity of rehabilitation therapies. And it was my responsibility to get them to the best level of care to portend the best outcomes. Again, that modified Rankin score at 90 days and 1 year. And so I looked at the clinical history amongst the people with aspiration pneumonia. So if they had any kind of vomiting followed by fever, if they had, again, this part in their x-ray that shows what they call an opacification, that whiteness, or the initiating of tube feedings. If you have a stroke, sometimes you notice your friends or family have a tube put into their nose to help them get food. Because if they eat, the food won't go into their stomach, it may go into their lung and cause this pneumonia. Among my 4,900 patients, about 270 had aspiration pneumonia, which is pretty prevalent. And you can see here, we were able to look at the types of stroke they had, more likely to have intracerebral hemorrhage or a hemorrhagic stroke, as well as whether they had tube feeding. You can see here, they were more likely. About 22.96% were receiving tube feeding compared to only about 2% of people who didn't have pneumonia. And so we then looked at some of the outcomes. I specifically wanted to look at length of stay. So if you had aspiration pneumonia, you're more likely to have nearly 3.4 times longer hospital length of stay. And if you required ICU care, 8.5 times longer ICU stay. So that made me realize if the patients are going to be in the hospital longer and they're going to be in the ICU longer, I need to start thinking about stroke rehabilitation inside the ICU. And I'll get back to that. It's where we're doing now, UT Southwestern. And so we looked at the overall results. These are the 3 levels of post-acute rehab care you can get. You can get inpatient rehab facility care, which I've highlighted. That's what you want. You get daily physician management. You get therapy services 3 hours a day, at least 5 days a week. There's a nurse there 24 hours a day. You can see the community discharge rate is about 76% compared to skilled nursing facilities. Look at the avoidable readmissions, only 2.6% compared to 10% from a SNF. And then within 30 days are also quite low. The length of stay is only about 12.7 days, and it can be expensive, which is the reason why, unfortunately, sometimes certain insurance programs don't cover inpatient rehab stays, and we have to fight and get prior authorization to get the stays approved. So you can see in my results with aspiration pneumonia. If you have aspiration pneumonia and a stroke severity of about 7, that's that NIH stroke scale, you're more likely not to go home. You're going to go to one of these levels of care. If you have aspiration pneumonia, a little higher stroke severity in the moderate range, you're less likely to get inpatient rehab. You're more likely to go to a SNF, you can see here, or a long-term acute care facility. If you have aspiration pneumonia, you're over age 69, you're not even going to the SNF. You're going to a long-term acute care facility. This is the same stroke severity, but if you have aspiration pneumonia, it knocks you down a level of functional status, and it decreases your access to intensive post-acute rehabilitation. So what did I do about this? Well, it was time to look at everybody's swallow on the stroke service. So we took care of, at that time, about 1,000 stroke patients a year. And so I made sure I did a specific type of swallow study on everyone. If you have a stroke in the back of your brain, there's something called silent aspiration. So if you're fed by the speech therapist or the nurse, they don't cough. There's no gag. The food just kind of goes down, so everyone thinks, oh, they're not having any problem swallowing, but it's a silent aspiration. That food's kind of going directly into their lung. And so we made sure that everyone actually had visualization of their swallow. So this is what they call a fiber optic endoscopic evaluation of swallow, or FEES, where they put a tube in your nose and they actually can see your vocal cords to make sure things aren't going here, through here, into your lung and down to cause pneumonia. But you can see here, it's kind of pooling around the side, isn't it? So there's a risk of this green liquid, which is what the speech therapist gives you, of spilling over and causing pneumonia. So this is an example of aspiration. We had every stroke patient be seen by a neuro-trained speech therapist before being cleared to eat. You don't eat unless the speech therapist says so. And if you're eating a non-regular consistency food, so if you're eating any kind of chopped food, puree, if you're drinking thickened liquids, you have to have a barium swallow, which is this one here, where you go down to X-ray and have you swallow barium to make sure it's going down into your esophagus and into your stomach and not your lung before we advance your diet. And so through these things, guess what? We decreased aspiration pneumonias. People were going home, we're inpatient rehab. This was directly from us doing this research and implementing this research at the center. So it's time to tackle urinary tract infections. So urinary tract infections are a complication that is completely avoidable. And I look at it as it's a ladder to the bladder. It causes problems. You want to get that catheter out. But I had to show that having this catheter in for a longer period of time actually doesn't just affect infections, it affects your access to post-acute rehab care. Thankfully, I collected that data too. 9 years ago, I did this study of patients with symptomatic urinary tract infection. And you can see I had a lot of patients in this study as well. And specifically, we looked at things when it comes to length of stay, complications, as well as outcomes. We had about 368 UTI patients out of 4,900. You can see how many here, 4,600 did not have UTIs. Again, similar thing, we looked at the type of strokes they have. Symptomatic urinary tract infection is more common among women. Hemorrhagic and ischemic strokes compared to TIAs, or transient ischemic attacks. People with increased stroke severity, remember that NIH stroke scale we talked about earlier. Increased length of stay, rears its ugly head again. People transferred to other acute care services. There are some institutions where if you have a stroke, the workup's been fully completed, and there isn't anything left neurologically to do, you actually get sent to another service. It could be the internal medicine service. It could be the family medicine service. If you are transferred to another service in our data, you're more likely to have a urinary tract infection, probably because the catheter stayed in longer than it needed to. And then patients with increased days in the ICU. Again, you got to start doing stroke rehabilitation when? While the patient's in the ICU. So similarly, guess what? If you have a urinary tract infection, you were less likely to get discharged home. And if post-stroke care was necessary, the patients with the UTI were more likely to receive inpatient rehab at a level just of lower functional status. They didn't go to inpatient rehab, they went to a SNF or an LTAC. And then think about it this way, for every point in stroke severity that increased, people with UTIs were 10.6% more likely to require continued care at an LTAC for every point. Imagine that, 2-point increase, 20% more likely to go to an LTAC. And the combination of premorbid urinary incontinence, UTI, had no additional impact on discharge disposition. So what did I do with this information? I tell you what, I realized that I needed to do more when it came to what's happening before and after going to acute stroke rehabilitation. I realized I needed to kind of intervene well before the patients came into the hospital, because if I was able to inform policy and practice of people coming into the hospital, I can affect change throughout the care continuum. So I am a stroke rehab doctor that decided to start doing pre-hospital research. I wanted to look at things when it came to preventing some of these problems from happening by preventing some of the actual impact of the stroke severity. So I want to look at this quote from Jeff Saver in 2006. So the typical patient loses 1.9 million neurons every minute in which stroke is untreated. Think about that, 1.9 million. And by looking at the specific quote, I decided that I needed to help portend better outcomes by essentially analyzing every kind of data set I can get my hand on to streamline the process of care, to get people who are having stroke into the hospital quickly, to hopefully get interventions, to keep them from getting complications and get them the rehab they need. So that starts before they even come to the hospital. These are some of the data sets I've been looking at over the past several years to help essentially create an entire streamlined data set from pre-hospital setting to post-acute rehabilitation, as well as readmissions to hospitals. And I want to really show what I did in the region. So this is something we've been working on within Dallas-Fort Worth, and it's a project looking at the network effect. So everyone knows about hospital networks in Dallas-Fort Worth and beyond. There are specific network hospitals that have 4 or 5 facilities, and then there are non-network facilities. And you have to wonder, if a person's admitted into a hospital network and they need to go to another hospital for a higher level of care for their stroke, are they going to the closer hospital or the closest hospital, or are they just going to another network facility? Because remember, 1.9 million neurons every minute. Are we expending neurons we don't need to? And so we looked at this essentially from a regional perspective. Remember this map and where we are here in Dallas? This is what they call Trauma Service Center E. So within Texas, we have these areas called the Regional Advisory Councils. Within Dallas-Fort Worth, we have something called the North Central Texas Trauma Regional Advisory Council. That's where we live. We live in Dallas-Fort Worth. It's about 19 counties, 9,286 square miles, and 7.7 million people. And I decided 3 years ago, I was gonna map stroke transport across this area. How'd I do it? Well, I conducted a regional survey of every single stroke center in the Dallas-Fort Worth Metroplex. It's about 44 of them. The response rate was at 100%. We looked at the geographic location, the network status, and the level of stroke care. So there's 3 levels of stroke care we looked at. One is an acute stroke-ready hospital, one is the primary stroke center, and then UT Southwestern and other ones are comprehensive stroke centers. What does that mean? That means that you could come in anytime, day or night, and there's someone available to intervene if you have a hemorrhagic stroke, if you need a neurosurgical intervention, if you need to have the clot pulled out, if you need to get TPA, there's someone always at UT Southwestern to treat you. We looked at stroke assessment tools like the NIH stroke scale, as well as large vessel occlusion tools as well. And what did we find? We wanted to actually map out Dallas-Fort Worth when it came to stroke care. So for acute stroke-ready hospital that transfer to comprehensive stroke centers, as well as primary stroke centers to transfer, we looked at the actual average distance. Simple enough, the distance between the transferring hospital and the receiving hospital. And if the closest comprehensive stroke center was not used, we looked at the distance between the closest one and the one they went to and mapped it out regionally. And what do we find? You can see here with all the colors, notice how they kind of cluster in Dallas, Fort Worth, and in the surrounding areas in Plano. Look at the southern counties. No stroke centers down there. Look a little bit further out west. Not as much penetration of stroke centers either. So we looked at the 44 facilities. 6 were acute stroke ready hospitals. You can see in the lighter blue, more rural areas. 27 were primary stroke centers, and 11 were comprehensive stroke centers. 77% were part of 4 main hospital networks. All the facilities use stroke assessment tools like the NIH stroke scale, and 57% completed large vessel occlusion screening, which is basically when a big clot is in one of the vessels, like in your neck or in your brain. And as a result, you can see there were no real transfer patterns. Look at this, it's called heterogeneity. Very sporadic, nothing was established. You can see among the transferring hospitals, 17% of acute stroke ready hospitals and 56% of primary stroke centers conducted transfers. Only 60% of non-network facilities transferred to the closest CSC, but if they didn't transfer the closest one, the average distance was pretty short, 1.5 miles. But look at the network hospitals. 17% of hospitals in the network, the 4 networks, transferred to the closest comprehensive stroke center. And if they didn't, the average distance between the hospital they chose and the closest one was 4.1 miles. So I don't know if y'all live in Dallas, Fort Worth, but if you're inside the city, 4.1 miles is a very long distance. And 1.9 million neurons can certainly be lost quickly every minute compared to 1.5 miles comparatively to 4.1 miles. So what did we do about this? Well, we changed the regional stroke plan. So the 2021 regional stroke plan focused on interfacility transfers to not just what hospitals in your network, but what the closest hospital is, whether it's another network or non-network, to streamline the transfer process. And we published this data last year in the Journal of Stroke and Cerebral Vascular Disease. So yes, I'm a rehab doctor, but I'm thinking about neurons and salvaging neurons and what we can do from a regional perspective to improve stroke outcomes. So then I went to the community because that's pre-hospitals, right? And I'm already there. And I'm thinking about primary stroke prevention and what actually are community-based needs. You know, I'm a clinician who works in a hospital. I have an outpatient clinic setting and I'm a clinical researcher. But it's really important for me to interact and engage with patients and their families and their caregivers regarding what they need and what they want and what's important. And what I've learned through some of my other research is that caregivers sometimes have worse stroke risk factors than the patients. I did a career development award for about 3 years. I found that the caregivers actually had worse stroke risk factors. I had one patient who had his stroke in January. His wife had a stroke in October because it's the same dietary patterns. It's the same exercise patterns. And I decided we need to figure out a way to reach the community at large that would be impactful and that would motivate us to express some change from a systematic level. And so we did that. We created something called the Stomp Out Stroke Education Festival. Now remember, this is all pre-COVID when we did this, but everything was actually done in a virtual manner when it came to recruitment. This was the original flyer from 2018 that was in English. Here it is in Spanish. We made it in Tagalog. We made it in Urdu. We made it in simplified Chinese because we wanted to make sure that we actually interacted with people. And here's me in the middle with a couple of my colleagues. And it was an outdoor festival. And you can see in the background, we're doing stroke screenings at this festival. We're doing high blood pressure screening. We're doing carotid ultrasounds, looking at the neck vessels that you have, make sure there's no plaque in them. And we did this over about a 4-hour period for 2 separate years. You can see how we conceptualized it. The study period was about 2 years. We did 2 large-scale health screening events, but it was totally web-based in recruitment. We used Twitter, we used Instagram, we use Facebook, and we have an active Facebook page with updated stroke literature. We even did virtual debriefings. This is pre-COVID. We did look at the demographics of the town we were in. We used a culturally competent approach, and we looked at the numbers of assessments that we could get done. We also did paperless registration and online data aggregation. And what did we do? We looked at some of the numbers. You can see here, these are some of the stroke survivors. They had their own specific tent. We had activities, we had dancing, we had multicultural interaction. You can see here some of the stroke prevention information we had. And we also had the number of people. Look at the age of the average attendee, 45 years. Remember that map of America and the stroke incidence of 35 plus? So this is right on target to help implement effective change. You can see here the majority of people there were women. A lot of caregivers were there. It was a multicultural and diverse population consisting of Hispanic, African-American, non-Hispanic whites, Asian, 2 or more races. We also had different ethnicities underneath Hispanic. A lot of people had kids. Health insurance was present, but a lot of people were uninsured, which was very important to us because we were doing free health screenings. You can see here, when it came to stroke survivors, 11.5% of the patients and participants in our study were stroke survivors. And so what do we end up doing? Well, during the 2 years we had these 2 health screening events, we completed 2,774 health screenings. If you put it in no uncertain terms, that is 4 health screenings per minute. You can see how many blood pressure measurements we did, over 1,000. Stroke risk assessments using the Framingham Health Survey, 496. We did bone densities, those carotid ultrasounds, the BMI, serum lipids, hemoglobin A1C for cholesterol. And then we asked real world questions. We looked at by ethnicity, why'd you come to the festival? What do you want to learn? Because a lot of times healthcare providers, we mean well, but we're not really listening to what you really want. I wanted to know what was really wanted and what was really needed. And so we provided overall health education. We provided stroke education. We also provided things like free health screenings, and we also provided family fun and entertainment. People got kids. You got to be able to entertain family if you're going to get these health screenings done. So we made sure we provided all of that. And we published information last year in the Journal of Medical Internet Research. So I want to kind of talk about the continuum of care and why I'm doing all of this. So you can see this is about, these pictures are 10 years apart. This was the old stroke unit I used to work in, and it was small. You can see stroke bed 7, stroke bed 6, stroke bed 5, stroke bed 4. But you know what was great about it? We were all together. So this is the, the continuum of care. That's me in the middle, and that's my mentor, Jim Grata. And you can see these are our speech therapists here. This is our nurse liaison. This is our actual charge nurse, neurocritical care doctors, speech therapists, telemedicine. We're all there together because guess what? It takes our whole group when it comes to the functional stroke recovery. There's no silos. And this is us about a week and a half ago at International Stroke Conference. Mentorship is really important when it comes to this and when it comes to any work when involving clinical research. And it's been shown that if you have a good mentor, you have someone who believes in you, you perform better at work, you advance faster in your career, and you actually have better work-life satisfaction. My mentor is available by cell phone at all times, and I'm always going up to him and saying, what else can I do to push the needle forward? What do you think of what we're doing here? And what do you think the next steps are? And he's encouraged me to continue to push forward when it comes to biologic plausibility, continuum of care, and next steps of what we could possibly do when it comes to research. And so I want to talk about what we do here at UT Southwestern. That whole community-based interdisciplinary team is really important to us here. And so we actually have a committee that I chair called the Stroke Continuum of Care Committee. And we're streamlining transitions of care to improve stroke recovery. And what do? Just like I told you before, these post-stroke complications cause long-term effects in access to care. We have to mitigate them. We want to prevent 30-day readmissions through the provision of early outpatient follow-up. You see me in clinic within 30 days of discharge. I make sure your medications are all on board, you get the appropriate therapies, you haven't had any falls, you're making sure we got your 30-day Holter monitor on, you have everything you need. We want to increase access to intensive post-acute rehabilitation at inpatient rehab facilities or outpatient therapy centers. We want to decrease your length of stay. Remember, we were talking about these things happen in the ICU level. So we need to start rounding from a stroke recovery perspective in the ICU. Everyone has to collaborate. There's no silos. You saw that picture of us in the old stroke unit. Everyone is there. All disciplines are there, present, active, working toward recovery for patients. And then we have to review progress with the stroke core team members, give feedback. What research are we doing? What are we publishing? What are we presenting? And that's the best way to affect long-term change and process improvement. So I wanted to show this video of our continuum of care. I hope y'all can hear it for sound. Let me know if you can.
Hello, my name is Dr. Nneka Ifejika, and I am the Chief of Stroke Rehabilitation. I'm also a consult physician in the Department of Physical Medicine and Rehabilitation. This video will prepare you and your circle of support for the next stage of stroke recovery. Care at our CARF-accredited stroke rehabilitation facility located in the Zale Lipshe Pavilion. There you will receive outstanding medical care by one of 3 physicians who are trained and certified in brain injury medicine. During the first week following your admission, I will personally review your imaging with the treating physician, the nursing and therapy managers, and our care coordination staff to facilitate not just a plan for your rehab hospitalization, but for your eventual transition home. Members of the medical team participate in weekly bedside rounds with you and your family, reviewing your progress with therapies, changes to medical management, and consultation with vendors for appropriate durable medical equipment.
My name is Nicola Rogers, and I am the inpatient clinical nurse manager for neurosurgery and neurology. During your stay, you will receive outstanding care from well-trained and competent staff. We look forward to visiting with you, and we thank you for trusting us to provide you with exceptional care.
Hello, my name is Molly Goff, and I am one of the speech-language pathologists on the therapy services team. As one of the primary stroke team therapy members, we may have met during your stay. After experiencing a stroke, many patients have difficulty with their ability to swallow, communicate, or trouble with their thinking skills or cognition, as well as physical deficits impacting walking and completing daily tasks like brushing your teeth or showering. As speech-language pathologists, we evaluate your swallow function, make the appropriate diet recommendations, complete formal speech, language, or cognitive evaluations as appropriate. Your physical therapist has evaluated your ability to move, balance, or walk after your stroke. Your occupational therapist has assessed your ability to complete typical daily tasks. Your physical and occupational therapist have also made recommendations on how you will safely transfer or move from one place to another. As a therapy team, we will work with you to create your therapy goals. We begin working on these things in acute care because we believe early intervention leads to the best outcomes. We also hope to prepare you for a more intense level of rehabilitation. Your therapy team on the inpatient rehabilitation unit will complete new evaluations and create therapy goals that carry over what we have been working on while here.
We thank you for your continued trust in the world-class stroke care provided at UT Southwestern Medical Center, and I will personally look for you on rounds and in the therapy gym. Stroke recovery is a combination of hard work, faith, and hope, all of which we provide and believe in as part of an integrated team. On behalf of the stroke team here at UT Southwestern Medical Center, we thank you for choosing us and look forward to being a part of your continued stroke recovery.
All right. So future work. Where am I going with all of this? And I put together this presentation for y'all. And you saw that I start pre-hospital, go to the ER, go through the stroke stay, go to post-acute rehabilitation. So what am I thinking? Where am I going with all this? Well, the next step is tying in biological plausibility. So you can see I've been able to establish that path that we talked about. I've been able to look at complications. I've been able to interact with all members of the team. We have a continuum of care committee. Where are we going next? Well, where we're going is to think about the importance of what happens inside the brain, the inflammatory process and the damage to neurons, and how it can be augmented, or how some things can be upregulated or positive and downregulated or negative when it comes to your acute stroke recovery. So I kind of want to show what normally happens. So you can see here, a lot of things happen with a stroke stay. We get CT scans of your brain. We do those 2 measures, the NIH stroke scale, the modified Rankin scale. Hopefully get some clot busting drug. We're able to pull the clot out. We're looking for all those complications. We get our MRI, then we look at discharge disposition. But what I want to do as a next step is tie in biological plausibility. Are there certain factors that are being upregulated if you have a bigger clot? If we pull the clot out, do those factors get downregulated? Are we able to stop the neuronal damage? If we are able to stop it, can we start rehab therapies even earlier than we're doing? We have this whole continuum of care, it's a perfect opportunity to test these biological changes. It's really important to look at it from that perspective because the world of stroke has changed immensely over the past 6 years. In 2015, 5 studies came out in the New England Journal of Medicine that basically showed if we're able to pull the clot out, we're able to improve outcomes at 90 days. I have seen patients literally come into the hospital with a high stroke severity, have the clot pulled out, and be able to walk out of the hospital. But what happens in the brain biologically to inform that practice is largely unknown. And what is the effect of rehabilitation on further advancing that practice is even more unknown. So my goal, again, is if someone attending tonight's Science Cafe had a stroke, came to UT Southwestern Medical Center, we will be able to, number one, evaluate the cascade of biomarker expression. Number two, match it to the type of rehabilitation that will be best for you. And number three, tailor an appropriate plan. And so we have pilot study to do this work. We're enrolling about 10 patients to start. It's been funded by the Mobility Foundation Center for Rehab Research. And that's the next step of stroke recovery, y'all. It's going to be tailored, personalized rehabilitation medicine based on what's being expressed in the patient's brain. And so my conclusions for y'all tonight: stroke is a prevalent condition whose incidence increases disproportionately in women with age. The process of stroke recovery begins at the onset of stroke symptoms. It doesn't begin on the rehab unit. It begins, like I said, pre-hospital, in helping choose which hospital you go to and how fast you get there, because time is brain. We need to have effective pre-hospital triage and communication in between network facilities. We have culturally competent primary stroke prevention with multimedia community education. And also, in-hospital stroke rehab benefits from the use of information technology, the entire team, like in the video, and clinical research that challenges traditional paradigms. You've got to think outside the box when it comes to stroke recovery. And then finally, you got to synthesize these concepts into innovative models of recovery using biological plausibility and biomarkers. And that is truly the next step to improving function. These are my references. And we have plenty of time for questions.
Thank you, Dr. Ifejika. Do you mind unsharing your screen so we can see everyone's faces? Thank you. So we appreciate all of the questions that we've received, and we're always grateful, but we especially received a positive outcome comment. So thanks to Robert for your comment in the chat. We're so glad you're here with us this evening. Now we're going to go into the Q&A portion of this session. While we can't get to all of the questions, I'd like to jump in because there were quite a few that were submitted ahead of time. Our first question is, are consistent migraines a precursor for having a stroke?
So there has been some evidence of migrainous disease increasing your risk of stroke, and that's actually an excellent question. That is a topic of research that is ongoing within the NIH and the NINDS. There hasn't been a direct correlation yet, but yes, it has been shown it could be a possible risk factor for stroke.
Not sure. How can we unshare that? Jenny or Charlie, could you help me with that? Thank you. Okay, I'm going to keep going with questions. So our next question was in the chat. It's from Jose. What is being done to ensure that hospitals are adhering to the new transfer recommendations for acute strokes?
Oh, I'm still on the committee. I've gone nowhere. So I'm actually doing a follow-up survey and mapping everything out again. Oh no, I go nowhere. So I'm the director of stroke research at Nicktrac. Yeah, it's me. So I'm actually making sure that the plan is being implemented. In addition, the outgoing chair of Nicktrac is an interventional neuroradiologist here at UT Southwestern, and she's also a co-author on the manuscript. We're keeping track.
Glad to hear that you're on top of it. Our next question, which was pre-submitted, someone says, prior to stroke, I could multitask. Will that become possible again? Will the left side neglect problem go away?
So if you have left side neglect, it's difficult because you probably had a cortical stroke affecting the right side. Multitasking is not just cognitive, it's also physical, and it also has the involvement of both those tracks in improving outcomes. If you're getting intensive speech therapy, I suggest you continue to do that. Day rehabilitation programs are also beneficial. And if they have any kind of home exercise programs, it will be exceedingly important. I usually recommend people actually do virtual rehabilitation as well. So they have wonderful online curricula when it comes to improving left neglect and neglect overall. Also, they actually have visual rehabilitation programs for left neglect. So if you have a visual field deficit that goes along with your neglect, look into occupational therapy for visual rehabilitation as well. It's going to take some work. It's going to take some time, but I have had patients have improvement with that. In addition, make sure your eyes get evaluated to see if it's actually not just a visual field deficit, but visual acuity related as well.
Thank you. Another question, what specific biomarkers do you plan on tracking as a dictator of outcome?
So I can't tell you that because I gotta get it funded. That's why I kind of took all that out of the actual presentation. That's in my brain. But if you get enrolled in the study, I'll be able to share the results of it later on. So when you're applying for grants, you can't always disclose everything because there could be somebody who said, that's a great idea. Let me try to scoop her. So I can just tell you the classes I'm looking at. I'm looking at neuroinflammation, neuronal damage, and thrombosis. And I have a set that I have chosen and researched, and we're going to look and see whether they impact outcomes.
Top secret information. Thank you for sharing that little tidbit with us. So this question came up a lot. It's in the chat and it was pre-submitted by multiple people that are here this evening. What can we do about prevention? Can you discuss the role of stress, diet, exercise, good and bad, on stroke causation and prevention? What insight can you give us for all the things?
Absolutely. So the number one risk factor for stroke is hypertension. Number one modifiable risk factor. And it's important to essentially go to your PCP, get your blood pressure checked, treat your blood pressure. Most of the time people feel like they have hypertension and it's like, it's not affecting me right now. It's a little bit high. Yeah, no such thing as a little bit high. They've become actually very aggressive when it comes to treatment guidelines for hypertension. That's one of the main risk factors. Stress definitely has an impact on your blood pressure. If you're in a stressed environment consistently, and stress also has cascades on other things. If you're stressed, you're most likely not exercising. You're most likely not eating right. You're most likely not taking care of things that actually help improve your inner joy. And that also increases your risk factors as well. I would say also any kind of overweight or obesity is a double threat, because if you're overweight or obese, you increase your risk of high blood pressure, diabetes, and high cholesterol. Those things are definitely modifiable risk factors. Things like family history can't be helped. We've got family history. If your mother had a stroke, if your grandmother had a stroke, if your father had a stroke, can't be helped. If you're a smoker, you can be helped. And tobacco use is also an increased risk factor for stroke. So there are a lot of things that we can do that are modifiable. And I didn't show the other map. I showed the map of stroke incidence age 35 and higher in the United States. I didn't show the obesity map. The obesity map maps directly onto it. It's not a coincidence.
Thank you. Our next question in the chat comes from Lori. What are early symptoms, if there are early symptoms, for a full-blown stroke following TIA?
So Lori, it's the mnemonic is be fast. So balance problems, visual problems, which is the E, facial droop, arm weakness, speech or slurred speech, and then again, time. Remember, every minute, 1.6 million neurons, and that's conservative 1.6 million neurons. So you want to look at those symptoms. Also in the chat about TIAs, we're actually trying to get rid of the term TIA because TIA is kind of a misnomer. It makes you think, well, it's transient, it's going to go away. But there's an increased risk of having a stroke within the first 30 days of having a TIA. So it's real business. So if you have any kind of risk for a TIA, you need to make sure you control your risk factors, get into your PCP, have full evaluation, get on appropriate medications to control those risk factors.
And Ted actually asked, can you describe for those of us who don't know, what is a TIA?
Sure.
Or formerly known as TIA, if we adjust the term as you suggest.
Sure, Ted. It's a transient ischemic attack. And the problem is the transient word, right? That means it's going to come and go. And that's like a false sense of security. So those same symptoms, like that balance issue, problems with your vision that goes away, blurry vision, double vision, facial droop, arm weakness, slurred speech, that kind of comes and goes. You have those symptoms, you present to the hospital, they get a CAT scan or MRI, and you don't have a stroke, but you do have the risk factors. When that occurs, you do have an increased risk within the next 30 days of having a full-blown stroke.
Thank you. Our next question comes from Carol. Can you describe the different rehabs for stroke patients?
Absolutely. So the one that I advocate for, and I mean like advocate for, is inpatient rehab facility care. And that's the one where you essentially stay in a facility minimum, usually about 10 to 14 days, and you receive daily therapies with physical therapy. So remember Molly in the video, occupational therapy, speech therapy, rehab nursing, and usually vocational rehabilitation. It's intense. You get about an hour of PT, an hour of OT, and an hour of speech every day. And you have to have measurable goals that can be achieved within that 2-week period. So you've got to have a level of activity tolerance and functional strength and endurance. There will be a doctor who is monitoring you and evaluating you and treating you every day. There's usually also pharmacy services. So here at UT Southwestern, we actually have pharmacy rounds, and we also have neuroimaging rounds. So even though I'm the consult doctor on Monday at CUH, I log onto Microsoft Teams and look at everybody's CT and MRI in the rehab unit on Monday at 10 a.m. So we're able to talk about the entire plan of what happened at CUH. I'm able to talk with about all the therapists, all the nurses, all the care coordinators, because they're in a different building, about what's happened on Acute and how that portends how we should approach the rehab care at Zell Lipsky in our rehab hospital. Now at a skilled nursing facility, things are a little bit different. This length of stay is longer, but you don't have to have 24/7 nursing care. The therapists are only obligated to come about 1.5 hours a day, about 5 days a week. And if you have healthcare, like a doctor, they don't have to come every day. They just have to make sure they come at least 3 to 4 days a week. So you can imagine the level of rehab intensity is not as high. The next level is a long-term acute care. That's for patients who are really still sick. It's basically like an acute care hospitalization for people who have been stable from a neurologic perspective. They also have ICU beds there. You can get some rehab therapies there, but you've had most likely a larger stroke. Most likely can't tolerate the 3 hours of therapy, but still need intensive medical monitoring and intensive physician care. Then there's outpatient therapy, right? So there's outpatient therapy, which is actually where you leave your house, you go to an outpatient therapy facility where someone from PT or OT or speech sees you for an hour or so a day. And they also have day rehab programs where you can go for about 5 hours a day. Then there's home health therapies. I would say if you're able to have transportation, you're able to get in and out of a car and do car transfers, do outpatient therapy. There's only but so much that can fit into a car. Think about it. If you get home health therapies, whatever the therapist could bring to you, right? Or whatever you have in the house. If you do outpatient therapies, you have a whole therapy gym at your disposal. All the equipment, all the technology, all the intensity, neurotrained therapists. And also with home health therapy, there usually aren't a lot of home health therapy speech therapists. They're usually in an outpatient therapy setting. Why? They gotta look at your swallow. Right? That whole feed where they're looking at your swallow and modified brain swallow, they have to have an x-ray machine. They have to be able to have that equipment, and they usually don't have that kind of thing that's portable in a car.
Thank you for walking us through those many options. Rebecca asks, if someone is not showing enough improvement in inpatient rehab, is there still a chance of improvement in a skilled nursing facility?
Absolutely. So a study just came out last year in the Proceedings for National Academy of Science called CPAS. It was by a doctor named Alexander Dromarek. And he shows through a study that people actually recover very well starting at 6 months. So if you can imagine, if you come into the hospital for acute stroke, you'll enter station about a week, you go to inpatient rehab for 2 weeks. If you go to a skilled nursing facility and stay there for a while, you may be hitting that 6-month mark when you're still actually at a SNF or outpatient therapies. So yes, the 6-month mark is actually the new acute measurement. So when patients come to me in clinic and they're at 6 months, I'm actually pushing their insurance even harder to get them into outpatient therapies at that time to really portend better outcomes. I know from the data, there's a second chance you have to get better. So absolutely, you can get better at a skilled nursing facility. You just got to make sure therapists come. I would tell you this, make sure you go to the facility where they don't know you're coming. Don't schedule a tour. Drop in for the tour. You want to see what the gym looks like. You want to see what the cafeteria looks like. You want to see what the rooms look like. And if they know you're coming, they're going to clean up. You want to see what it looks like real time. So if you're going to look for any kind of sniff for your family member, you pop up on them. Just say, boo, I'm here. You know, show me the gym, show me the cafeteria, show me the kitchen. You want to know, because that's the real world, right? You don't want that kind of false sense of what the place is. You want to know what it's really like day to day. So I do recommend, checking out the facility in person, not virtually, in person for your family member.
That is tremendous advice. Jenny asked, where can we get a comprehensive list of stroke centers?
The Joint Commission has a list online, and so does Nicktrac. There's actually a virtual tool that's on the Nicktrac website, if y'all search for it, where you can actually pull up all the stroke centers in Dallas-Fort Worth by their designation. So you can see which ones are acute stroke ready hospitals, primary stroke centers, and comprehensive stroke centers. So you can see that. There's also something called a thrombectomy capable center. It's kind of in between a primary and a comprehensive. They can pull the clot out if you show up and you have a large vessel occlusion. However, they may not have a neurosurgical team there all the time. So you really want to live near a CSC or go to a CSC if you want to have 24/7 outstanding care, which is what we have at UT Southwestern.
Speaking of, Christy asks, if you live in the DFW suburbs, is it better to go to UT Southwestern or your local hospital in case of stroke?
Okay, so time is brain. Y'all are going to hear me continue to say this, right? So if you're having a stroke, I want you to get to the closest hospital to get you stabilized to save your brain. So when you have a stroke, we classify it this way. You have a core stroke, which is kind of the middle of it, where brain is likely died. Then you have an area called what they call the penumbra. It's an area where the brain is kind of stunned, but if we're able to pull the clot out, we can save that area. So as a stroke rehab recovery doctor, I want to save the penumbra. So if you're somewhere in the suburbs and you're having any of those symptoms of, balance problems, eye problems, facial droop, arm weakness, slurred speech, go to the nearest stroke center. You can always find us later for recovery. We can handle that, but I need you to save your penumbra. So you need to go to the closest center.
Thank you for your honesty. Jan asks, a large percentage of people with migraines have a PFO. Can this account for increase of stroke potential?
So, in case y'all don't know, PFO is a patent foramen ovale. It is a hole in your heart that about 10% of the population has. Most people go through their whole life with a PFO and don't know a doggone thing about it. However, if you have a stroke and they're able to find the PFO and you have evidence of having clot in your legs, where we do like an ultrasound of your legs, take a look there. That could be etiology for stroke, yes. The closure versus no closure in people who've never had a stroke, there's no evidence that's gonna actually decrease stroke risk. But if you do have a stroke and you have a PFO and they find clots in your legs, we do recommend them closing the PFO depending on the characteristics of it. So they have some PFOs that are like an obvious hole, right? Then they have some which are called kind of like fenestrated, which is kind of like little holes, almost like the screen porch. Y'all have a screen in the porch, it's like you can see these little holes let the air through. They call it, it's fenestrated. Those type of PFOs versus ones with the actual open hole. Then they have something called an atrial septal defect, which basically means it's like a huge hole where the septum never really closed. So it depends on the type of PFO you have, where you would talk to the cardiologist and you come to a plan about, would closing this really help me? What's the risk benefit of it? Is the PFO calcified? Are there other problems going on? So it depends on the type of PFO, the screening for the stroke, the type of stroke you had on imaging, and whether you have clots in your legs.
Thank you. There's a question that's in the chat, and it was also asked ahead of time by a few people. Can stroke symptoms resemble other diagnoses such as multiple sclerosis?
So this is one of the main fears of a stroke doctor, is missing what they call a vascular occlusion. And I will tell you the symptoms. The symptoms are a patient passing out and waking up. So if you can imagine, syncope, if you have any kind of heart condition, is very similar, isn't it? Or just feeling lightheaded or having any kind of low blood sugar, very similar, isn't it? Where you kind of pass out and wake up. So there are types of strokes that resemble other things. The concern about when you have MS and then you have a stroke, it's sometimes difficult to ascertain which one it is. I have multiple MS patients who also had strokes. And you really have to look at the type of imaging you're evaluating to determine what's what. And it requires the workup. So you can have MS and have strokes as well, particularly if you have the vascular risk factors, but you need to make sure that you go to a stroke center that can help make the differentiation.
Thank you. Another question about differences. What's the difference between cerebrovascular disease and stroke?
Oh, Stroke is a type of cerebrovascular disease. So there's all kinds of cerebrovascular disease. There's aneurysmal disease, where there's a dilation of a blood vessel. There are intracerebral hemorrhages, which is another type of stroke. They're all underneath the cascade of cerebrovascular disease. So it's just a type.
Thank you for clarifying that. I'm going to just do a few more questions because we're quickly running out of time. Can you comment on the role of neuroplasticity and recovery?
Oh, yes. And so that's the whole point of rehab, right? So the brain is a glorious, glorious organ. Now, I'm not just saying that because I do this for a living, but it is. And so the goal is through rehabilitation is to look at the areas that were around or around that were next to the area that was damaged and try to get them to take over some of the functional tasks for the damaged area. And that's what plasticity is, right? It's getting your brain to have more flexibility to take over tasks that it didn't do before. That's why it's important to do rehabilitation, because you're basically retraining your brain. I liken it to being a marathon runner, right? You can't just jump up and do Boston Marathon. You got to train for it. And this is the exact same thing when it comes to stroke. You've had a stroke, it's affected one specific function. You have to train the brain through neuroplasticity to take over that function. It may not be perfect, but it will be something that could be functional for you to be able to use and be able to recover a new normal for yourself. And that's the purpose of rehabilitation. That's why we push so hard to make sure you have access to it, that you don't get infected, that we give you all the therapies we can. We figure out what's going on inside the brain biologically. We need you to have better chances for plasticity, better chances for recovery.
Thank you. Next question is, do you have any theories as to why younger people are having strokes? What's the age we should typically be concerned with strokes, and has that age moved up in recent years?
Oh, I've got theories. I've got facts. Have you seen the size of a McDonald's Happy Meal and the secular increase in it over the past 20 years? I see people laughing. You know it's true. You know it's true. I remember when I was a kid, the size of a big gulp in the 7-Eleven was, I think that's the size of the small in the 7-Eleven. There's been this secular increase in the amount and types of foods that we eat and the saturated fats in the foods that we eat. And if you look at it, there's a lot more obesity amongst children. It's something that our society is dealing with. And what was that risk factor I told you was tied to all of it? Obesity, right? As well as a sedentary lifestyle. So it's not a secret to stroke doctors. We know what it is. It's the fact that things have changed a lot when it comes to our society and what we're eating and our physical activity levels has definitely decreased the age of first stroke. One of the first papers I wrote that I published in stroke, they had me check the age of it. They said my age was too young and it had to be incorrect. I sent them the raw data and my age was completely accurate. It was just the age of the stroke are getting younger and younger. And it's something that we're going to have to deal with because we can't have people in their 30s entering Medicare in their 30s. Like it's something that's going to be very important because this is a disability burden. You're supposed to be able to work, care for yourself, care for your family members, care for your parents in your 30s. It's a different, and the fact that things have changed so much when it comes to disability related to stroke is disconcerting, but there's definitely been a decreased age in stroke, and that's part of the reason.
Thank you. The last question, can you please discuss the correlation between stroke and eye damage?
Oh, no, that's great. These are great questions. Y'all are brilliant. So there's different types of stroke that affect different areas, all right? So there's one specific type of stroke called a central retinal artery occlusion. So that artery comes off of the carotid that can actually literally cause you blindness in one eye. But then there's also cortical stroke, which affects the gray matter of your brain and thus causes something called cortical signs. Cortical signs, what we talked about earlier, like that neglect, the visual field deficit, the inattention, or the hemisensory loss, along with the weakness. So you can have it from an actual stroke that affects your eye, an actual stroke that affects the cortex in the front, or the back of your brain, which is where all your visual centers are. So it depends on the location of your stroke.
Thank you. With that, I'm going to pass it to Jenny.
Perfect. Thank you so much. That was wonderful how you connected the dots for us between your research, your ongoing research, what it means to have post-stroke rehab as a pre-hospital concept, Thank you very much for what you're doing and for being so clear with us. Thank you to my colleagues Charlandra and Joya for helping with tonight's event, and to all of you for joining us. I hope you're warm at home. We hope you will join us again in 2 weeks on March 10th for the next Science Cafe. It will be on colon cancer, and we have 3 of our faculty members, as well as Cint Marshall, who is a very proud and outspoken colon cancer survivor. She's proud about it because she's going to talk to you anytime she sees you about getting screened. And so we're thrilled to have her on our show or episode. And we hope you'll join us. And then on March 24th, did you know that you could give part of your liver to your neighbor to your family? It's called Living Liver Transplants, and we'll be talking about that on March 24th. We're going to put those links in the chat. And we are getting back to a new normal. It feels good, but we still want you to wear your masks when you go to the grocery store. Make sure you get your vaccines and your boosters. And we hope you stay well, stay warm, and thank you again for joining us. Have a good night.
Thanks, everyone.